Hi, this is Brian Kim. I'm going to share with you case number 41 in the best way to do cataract surgery series. This is a very small pupil soft lens, and I'm just going to show you how I'm able to use double chop, cross chop, mechanical fracturing forces to very easily and systematically disassemble this lens, even without great visualization. A lot of people get hung up on being able to see everything when you do cataract surgery, and in my opinion, being able to know where your instruments are within the capsular bag, hooking pieces, crushing the lens piece, it is such a more versatile way to do cataract surgery. I'm not going to be really missing a ring here. And so these are the two tough situations. A very soft lens, which tends to cheese wire, very difficult to grasp with high vacuum, very difficult to sculpt and then crack. And then on top of that, a small pupil. You're going to see how easily I'm able to disassemble this lens. So you can see I'm going to use my cotton tip to help center the eye, and then I'm going to use my corneal marker, which will help me to center and size my rhexis. When you have either very big pupils or small pupils, that corneal marker is really quite helpful to help gauge the size of your rhexis. I use the cotton tip to turn the eye and make my paracentesis incision, making sure I'm flat to the iris plane, first superiorly on the right and then inferiorly on the left, and I can get a nice self-sealing corneal incision this way. I'm injecting some intracameral lidocaine, and then I'm injecting some intracameral epinephrine. You can see that the epinephrine is not really dilating the pupil very much. And then I'm injecting some dispersive viscoelastic to inflate the anterior chamber. You can see it's causing a little bit of viscodilation, but this will go away once the eye is decompressed. I'm doing my triplanar corneal incision. I make a vertical groove, tunnel through the deep part of the groove into the cornea, and then dibble down. That's a triplanar corneal incision. I'm using the cannula to help manipulate the eye away from me so I can get a really nice corneal incision. This is my puncture style Capsulorhexis. I puncture in the middle, and then you can see here it went to the left, and so I went ahead and went with it. You want to follow wherever the tear goes. In this case, it went left. I went ahead and grabbed it and started to create my flap. And again, because this is a smallish pupil, I'm able to take advantage of that smallish size pupil. I'm going around circumferentially. In this case, I'm trying to make the rhexis just slightly larger than the pupil edge. Rub some viscoelastic to decompress. Do the Capsulorhexis hydrodissection technique. Place the cannula out to the contralateral equator. In the Capsulorhexis, turn the tip down, and you can see I get a nice fluid wave there. Turn the tip up so it's flat, come out of the bag, decompress on the left side, sweeping a little bit, and then trying to do the same thing on the other side. This is a bit of a soft lens, so as I'm trying to turn the lens, it's not really turning very easily. It's because the cannula is just cheese wiring through the lens material. So I'm going to start the phaco. I'm starting the irrigation of the surface of the cornea, lift the incision with the chopper to minimize any trauma, and then I'm going to remove the surface epinuclear material, bevel down. That epinuclear ridge ensures that I'm going to be underneath the anterior capsule, out with the chopper, place the phaco tip vertically, sub-incisionally, crushing the lens and bisecting it with a double chop, place the chopper out to the contralateral equator, pulling it centrally towards the phaco tip. That's the cross chop, bisecting the right heminucleus. I'm using the chopper to support the pupil, making sure it doesn't go to the tip, and then I pull the first quadrant up out of the bag with high vacuum and emulsify it. I place the chopper around the second quadrant, hooking it, pulling it up and out of the bag, and then emulsifying it with the phaco tip in the central safe zone. Rotating the second heminucleus in front of me, placing the chopper out to the equator, and then crushing it against the phaco tip. You can see the third quadrant came out quite nicely with vacuum. Place the chopper out to the equator, crushing it against the phaco tip again for the fourth quadrant, and you can see the lens pieces are just starting to come out very nicely. I pull that last piece up with high vacuum, and I start crushing it and then aspirating the lens pieces. I'm removing the epinuclear material now. In order to be very clear, again, the chopper is doing all the work, hooking the lens pieces, but I want you to understand the name double chop comes from the fact that the phaco-tip acts like the chopper as well. So the phaco-tip has two purposes: the traditional emulsification role, but also in my technique, it functions as a second chopper because I'm always crushing the lens piece with the chopper against the phaco-tip. And so when I'm doing the chop maneuvers, I'm placing the phaco-tip sometimes deep in the bag, sometimes in the periphery, but during those steps, it's posing as a chopper. I'm not using any aspiration or vacuum whenever I'm doing those maneuvers. If I did, that would be very dangerous. So again, in those moments, I'm using it as a chopper, not using any fluidics. It's just using mechanical fracturing forces, again, without aspiration or vacuum. So you can see I did the INA to remove all the cortical material, and then I switched to the polish mode, and I'm trying to go around underneath the anterior capsulorhexis edge, cleaning up any potential lens epithelial cells. Again, because I cannot visualize a tip, I prefer the polish mode because it's much lower vacuum and aspiration, so I can very confidently and safely clean the bag. With the cannula, I'm going to push some BSS into the subincisional capsular fornix, but I'm doing this very gingerly because I really can't see the edge very well. You can see I'm just trying to remove some extra cortical material that I can see still stuck to the posterior capsule. I'm using the polymer tip to very easily and safely remove the lens material. I go ahead and inject some cohesive viscoelastic to inflate the capsular bag. But then I decide, I really can't see well enough to sweep, so I'll go ahead and just inject the intraocular lens into the capsular bag. I turn the eye so that I can make sure that I'm completely in the bag. And then I go in with the INA, making sure that the leading and trailing haptics are disengaged from the optic. And then I use a Maltzaman to make sure I can retract the pupil, ensuring that the entire lens, including the haptics, are in the bag. And with the Maltzaman, I can confidently tell that the entire lens is in the bag. And the fact that I'm able to tilt the lens and it doesn't tiddlywink to the left or to the right tells me that both haptics are indeed in the bag. And I'm able to tilt the lens, making sure all the viscoelastic is outside of the bag. Once I ensure the entire lens is in the bag, I'm going to go ahead and switch to the viscoelastic removal mode and remove the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, you can see soft lenses are really difficult for a lot of people because sculpting can cause the lens to just fall apart, and you try to crack a soft lens. It's really a big challenge. And then trying to grasp the lens with traditional chopping techniques using high vacuum to hold the lens will fall apart as you're trying to hold the lens for the chop. So a lot of people in these situations just choose to prolapse the whole lens up. That's why they like to do these flip techniques. But again, that's because their techniques can't really handle the soft lens and the small pupil. Especially the small pupil part, they use rings and hooks, etc. For the soft lens part, they have to prolapse the whole lens up out of the bag. Again, you can do this and that's fine. It just reminds me that that's a limitation in their technique. And so you can see with this technique, it very easily, systematically breaks the lens up. A long chopper with a safe tip is really the best way to get out into the capsular fornix. Just mechanically, intuitively, it makes the best sense for me to do it this way. And that's why I do feel this is the best way, most efficient way to hook pieces up out of the bag, despite poor visibility and despite a very soft lens. So I hope this was helpful to you, and I thank you for your attention.